Well, let's go into this here. We got this compartment syndrome. All right, compartment syndrome. And what is this here? I'm just gonna show you a picture. That will be, that's crazy. Let's see if there's one picture before the surgery one. All right, let's, well, this one is one after the surgery here. Let me go this way. This one here. That's crazy, let me tell you. What happens in here is the following. Do you remember about the compartments? Okay, the anterior compartment, the deep posterior compartment, superficial compartment, all these compartments in here, if the patient goes through trauma, all right, what happens is that, you know, bleeding and inflammation is just going to take place in here, and those compartments are going to inflame. And remember, ladies, you have vessels going close or through these compartments in here. What's going to happen is that inflammation, that swelling that's taking place in there, that bleeding that's taking place in there, it's just going to compress these vessels in here. The problem is that if the patient is not attended real quick, this will lead to necrosis very fast. And they're going to ask you this in your test. You're going to ask you, hey, what's the treatment of election for one compartment syndrome? And it's something that we call fasciotomy, all right? Which is basically, remember the muscles, they have a fascia. You're just going to remove it to what? To release the pressure inside the compartments. And then that should solve the problem that the patient has. But that's something that is an emergency. Let me tell you, compartment syndrome is an emergency. Because if no, the patient is going to have muscle necrosis. That's very bad. And the reason I'm telling you this, hey, compartment syndrome is an emergency, is because you need to differentiate between the compartment syndrome and the entrapment syndrome. Entrapment syndrome is not an emergency. Entrapment syndrome is a problem. It's like a congenital defect. Let me show you this right here. Those muscles in here, those are the calf muscles, the gastrocnemius one. And we have a medial head and we have a lateral head. Look at the normal insertion of the medial head of the gastrocnemius muscle. A normal insertion is just going to go here. What we call the medial condyle of the femur right here. That's what it happens. But it never goes over the popliteal artery here. Now the problem is that, look at this here. Look at this patient. Look what happened. The insertion of the muscle, or in other words, the origin of this muscle right here, is just like going over the popliteal artery right here. Can you see it? So what happens is that when the patient do what we call a plantar flexion, like this, like if you were pressing the pedal of your car, all right? So what's going to happen? The muscle is going to contract, and it's going to what? And it's going to compress this artery, and then the patient is just going to complain about this tingling sensation, claudication in the calf area because the popliteal artery is being what? Is being compressed. So if you have something like this, entrapment syndrome, and you suspect the patient has this, you can do the following. You get a picture. Remember, in your machine, you have dual screen. In one screen, you can tell the patient, hey, look, I'm just going to take the picture and a Doppler of your popliteal artery, right? Very good waveform in here, all right? triphasic, very good, perfect. But then when you tell to the patient, hey, can you do a plantar flexion right now? See what happens? The artery disappears from the picture because it's being compressed. Plus, what happens to the Doppler signal? Boom, it went away. Now, let's go back in here and let's take a look at this. Compartment syndrome, remember, has to do with trauma, has to do with bleeding, inflammation, all right, swelling in those compartments, which is going to lead to necrosis if this patient is not quickly attended. All right, so this is a medical emergency. And what's the treatment of election? It's going to be something that we call fasciotomy, which is basically releasing the fascia of the muscles to release the pressure. Okay, that's something done by the orthopedics. And then the entrapment syndrome is something different. There's a problem. There's a congenital problem where this tendon in here, the origin of this gastrocnemius muscle, which is the medial head, remember, not lateral, medial head. If you want to take that note, that will be perfect. Medial head, that's the one that is giving you the problem. Because it's just going over, this tendon is just going over the popliteal artery. And when you do a plantar flexion, it compresses the popliteal artery, right?
So now we're going to move on to the upper extremity veins. The deep veins are subclavian vein, axillary vein, brachial veins, radial veins, ulnar veins, which are here, as you can see. And then the superficial veins are the cephalic veins and basilic vein. Okay, now we're going to go into more detail about them. So the deep veins of the upper extremity, like I said, is a subclavian vein, which is created by the confluence of the axillary vein and the cephalic vein. So here you see the axillary vein connecting into the cephalic, or the cephalic dumping into the axillary, and then that confluence then becomes the subclavian. So the connection between the axillary vein and the cephalic vein creates the subclavian vein. Now, the axillary vein, it's created by the confluence of the brachial veins, which are paired veins, the same as the radial and ulnar, they're paired veins. So that confluence with the basilic vein creates the axillary vein. So cephalic and axillary for subclavian, brachial and basilic for axillary. So now the brachial veins are created by the confluence of the radial and ulnar veins here. The radial veins are created by the, the palmar arches down here, which we're going to go into in a second. And they empty the lateral, so the radial veins empty the lateral side of the hand and the forearm, and then the ulnar veins empty the medial hand and side of the forearm, here and here. So one is medial, one is lateral. Now the superficial veins of the upper extremity are just the cephalic vein and the basilic vein. You also have this small connection between the cephalic and the basilic at the cubital fossa, which is called the median cubital vein or antecubital vein. Some different people call it different things, but just know that that is a connection between the cephalic and the basilic. Has nothing to do with the with the deep system. It has to do with the superficial system. The cephalic vein, again, is created in that connection between this axillary vein and subclavian vein. And the cephalic is actually the longest superficial vein in the arm, okay? In the whole body, the longest vein is the greater saphenous vein. But in the upper extremity, the longest vein is the cephalic vein. And like I said before, when we were talking about the fistulas, The basilic vein perforates the deep fascia about midway, like through here, up the arm, and drains into the axillary vein. So that's why they usually prefer the cephalic vein, because it's a lot easier to access. For fistulas, you know, for the basilic, they would have to transpose that vein and move it a little bit in order to be able to do the fistula. So it's a little bit more invasive. So the only case where they would use the basilic vein is if the patient already had a cephalic, a brachiocephalic or a radiocephalic fistula, and that fistula failed, or if the diameter of the cephalic vein is not good enough to be able to use it for the fistula, so they go on and use the basilic vein. So now we're going to go over the deep palmar arches. The deep and superficial palmar arches, arterial arches, are accompanied by the deep and superficial venous arches. So the common palmar digital veins up here, they drain into the superficial arch, then which is here, superficial palmar arch, and then they drain into the palmar metacarpal veins, then into the deep arch. Those deep arches then connect into the radial vein, and then the superficial arch connects into the ulnar vein. So just go over the diagram. Like I said, the best way to learn this is drawing it out, especially as sonographers. We don't really deal with this. We mostly, you know, go down to the radial and ulnar, so then everything below that, it's kind of like gibberish. So just make sure to go over it and draw it out. That's the best way to learn it. So you're gonna have that deep. This is a deep palmar arch for the veins, and then this is the superficial palmar arch for the veins. So it starts in the digital dorsal veins down to the metacarpals here, then it connects into the venous network arch thing, and then it connects into the cephalic and the basilic. The cephalic, again, it's lateral, the basilic is medial. So that's, just always remember that. And it's going to really help you for fistulas too, just knowing what's the location of your cephalic and basilic. You know, remember that one is lateral and the other one is medial. So now, any questions about the upper extremities? The anatomy? No? You're good? Okay. So now we're going to go into lower extremities. I like this part because we do DVTs a lot, you know, regardless of what setting you're in, whether you're general, vascular, you're always going to do a DVT study, even if it's a basic study. So, you know, these are things that you're actually looking at, and sometimes you're not really thinking about it and don't really know what are those branches that are coming out. So being able to learn the anatomy into a little bit more extent and more into depth, it really helps, because sometimes you're going to have a clot in those little branches that you don't really know about, and that's the reason why the patient's having pain, but you don't know how to document it, or you don't even know that that's a clot. Maybe you think that that's a hematoma. So it's really going to take, you know, your scanning skills up a notch, and you're going to be able to help the patients a lot more. So the deep veins that we have in the legs are the external iliac vein, the common femoral vein, the femoral vein, the popliteal vein. Remember that the femoral vein, they no longer use it as superficial femoral vein because of the confusion that the treating physicians had, that, oh, if they call it superficial femoral vein, it's a superficial vein, so it's not a deep vein thrombosis. So now that's no longer used. It's femoral vein, okay? You're gonna have the femoral vein, the deep femoral vein or profunda, the popliteal vein, the anterior tibial veins, posterior tibial veins, and peroneal veins. And you're also, the gastrocnemius veins are deep veins, okay guys? So you, gastrocnemius veins are very frequently have DVT, like, and that's a DVT that you're able to obtain very easily because they come off the popliteal vein. Okay, so right up the popliteal fossa, when you're getting that image, you have the gastrocnemiuses and the small saphenous vein branching out. So even if that's not part of your protocol, if you can just take a look in there and make sure that those are good. It's not like you have to go out of your way and look for something else. It's right there in your shot. So, and the superficial veins that we have are the small saphenous vein and the gray saphenous vein. Like I said, the gray saphenous vein is the largest vein in the body, and that's why they like to use it a lot for bypasses in the heart, and grafts in the leg, and everything that they can think of. So now we're going to go into depth with the deep veins of the leg. All right, so the external iliac vein becomes the common femoral vein when it passes the inguinal ligament right here. External iliac passes the inguinal ligament, becomes a common femoral vein. Then that confluence between the deep femoral vein and the femoral vein, the proximal femoral vein, is the one that creates that common femoral vein. All right, so then you have mid, distal, then popliteal once it passes through the adductor hiatus. All right, it becomes a popliteal vein. I think it's a little high, but sorry. All right, so now down here, I'm sorry, everyone's going crazy right now. Anyways, so down when it becomes a popliteal, you're gonna have that gastrocnemius vein branching out from the popliteal vein, and as well as the small saphenous vein. Then you keep going down, down, down. Then it at the calf, the proximal calf, you're gonna have the anterior tibial vein and the tibioperoneal trunk. That tibioperoneal trunk bifurcates into the posterior tibial vein and the peroneal veins. Okay, a lot of people sometimes they forget that there's a little junction there before the other ones bifurcate. So yeah, the anterior tibial veins empties the front of the leg, posterior tibial veins back of the leg, peroneal veins the lateral leg. And just go over, I'm gonna just throw it out for you guys real quick. That way we can go over.
Yeah. You said that the gastrocnemius is the first branch off the pop.
So it kind of just bifurcates out. I think the small saphenous vein comes out first.
Is that little knob above that in the image?
This one? This one? That's probably the small saphenous.
Okay.
And then this one is the gastrocnemius, and the gastrocnemius actually has a medial and lateral. So you're gonna have like two, and they have their own little vein as well. They're paired.
Oh, it's paired. Do you have an image?
Yeah.
Ultrasound? Okay.
Yeah, I'm gonna go through that later on in the lecture with you guys. Okay. So let me just show you.
And the soleal is gonna drain into posterior tibia, right?
For the peroneal, either or.
Perfect. Thank you.
And they're down in the leg, so that's another one that is easy to evaluate if you already look for the posterior tibials and the peroneal veins, because it's right there. It branches out from the posterior tibials or the peroneals, and if there's a clot there, you're going to see it. It becomes very dilated. So let me just connect real quick. My tablet. All right. Okay, so we're gonna have the external iliac vein. There's gonna be the inguinal ligament. All right, inguinal ligament. Then when it passes that, it becomes the common femoral vein, so EIV, CFV, and it bifurcates. So FV, CFV, prox, mid, distal, and when it passes through the adductor hiatus, let's just put like that there, it becomes hiatus. It becomes the popliteal vein. So, you know, good question. The first branch usually, there's a lot of variations in where the small saphenous originates. Sometimes it doesn't originate from the same place, but you know, for testing purposes, just remember that it would come off the popliteal vein. So that would be the small saphenous. This would be the gastrocnemius. And then it would, you know, a little bit after, it's going to branch out and create like one that goes medial and another one that goes lateral in the leg. So SSV and gastrocnemius. Then we keep going down and it's going to bifurcate into the anterior and anterior tibial artery and tibioperoneal trunk. It's just a small segment and then it bifurcates down. I'm just drawing it out as a singular vessel now because it's easier, but as you guys know, these are paired veins and these are paired veins. So tibial peroneal trunk, then peroneal veins, posterior tibial veins, anterior tibial veins. And the soleal veins, like they said, it's usually going to come out from either these, the posterior tibials, or the peroneal veins. All right. So there's a lot that you can evaluate when you get down to the pop. So past the pop and in the calf area, there's a lot going on. And as you guys know, off of the CFV here, you're going to have your, well, actually it's going to be on this side. You're going to have your greater saphenous vein as well, all the way down. GSD.
So our pop vein is below the gastrocnemius.
The pop, what do you mean? It's
where's
below?
the pop vein in this
So
image?
this is once, so pretty much the femoral vein, it's kind of like the same continuation once it crosses the adductor hiatus.
That's the pop
This
vein.
here is the pop.
Yeah.
The gastrocnemius veins come off the pop,
Okay.
and the small saphenous vein comes off the pop, or drain into the pop. But that's how you would see it. And I'm actually going to show you guys right now as well. I'm going to scan my leg real quick. That way you guys can see. Let me just turn this off so I can see. All right. I'm just going to show you that fossa real quick. And like I said, being able to getting clots in the gastrocnemius vein is very, very common. and in the soleal vein as well, because the soleal vein doesn't have any valves. So when you don't have any valves, you're not able to, for the flow to go back up as good. So it's very common. All right. Okay. All right. So it's kind of hard to scan yourself. All right. So this here is one of the gastrocnemius veins. This one here.
Can you show the pop to get a reference?
So pop here. Pop artery